Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Regeneron Pharmaceuticals, Inc. and Sanofi, developed through a strategic collaboration between the COPD Foundation and Medscape.
Hi, I'm Fernando J. Martinez. I'm a professor of medicine at the University of Massachusetts Chan Medical School in Worcester, Mass. Welcome to this program that's titled Advancing COPD Care Through Precision Medicine, Patient Empowerment. It's quite a title. Two of my colleagues here. Haley, you want to introduce yourself?
Sure. I'm Haley Hoy. I'm a nurse practitioner at Vanderbilt Medical Center.
And Barbara?
I am Barbara Yon. I'm a family physician at the University of Minnesota and family and community health.
All right, welcome you too. For the audience, I want you guys to just take a second and just think about a time recently when one of your patients was seen, was reporting that their COPD was worsening. How did you conceptualize that? What did you do to assess their symptoms? How did you communicate? Were there gaps with the patients or sort of challenges that you felt hindered assessing that patient? All right. With that in mind, that's how we're going to start the program here, Haley and Barbara, which is really to try to get a sense of initially communication strategies for assessment. So I think all of us are aware that COPD is a heterogeneous syndrome. It's a complex disorder that is characterized by multiple different components. It is associated, unfortunately, in many patients with a progressive process that's associated with acute events, these exacerbations with lung function decline, worsening of morbid conditions, and in many patients, unfortunately, eventually death. Can you two just sort of give me a sense of how you envision the discrepancies that are present between how clinicians view patients, how the patients view themselves, and how the patient's caregivers view the entire process? Barbara, I'll start with you and then turn it over to Haley.
Sure. Well, I think there is a very large discrepancy often because remember, we see a patient usually sitting in a chair or up on an exam table. Frequently, we don't even see them walk into the office. So our perception of their ability to move, their shortness of breath, all of those things, as well as what they do in their daily lives, is really very limited. And frequently, if you look in a medical record, you have no idea of what they do every day or what they want to do every day. And so, with that, I think we have to really talk to the patient about what is it that you can and can't do? What is the burden of disease? What are your goals? What do you think we're doing? So there is so much in this condition that we really have to. We don't have a simple test. I can't do a hemoglobin A1C for COPD and have a sense of where they are. So a lot of this is communication. And as we all know, what I think I say to a patient or a family and what they think I said can be very different. And that's why I need to check again and again. Haley, it's probably the same for you.
Very much so. I echo what Barbara says. And, I think we can't underestimate how much our patients want to please us. And we ask them how they're doing, and they want to say great, and they want to be very polite about it. But in years past, when there was Not as much that we could do for COPD patients. They were more of our easy patients in and out with refills. And I think now we need to concentrate on asking them specifically what they are unable to do now that they could a year ago and delve a little bit more into their quality of life.
Yeah, I have an example. One of the things that I say is I asked a gentleman who was sitting there, well, how, can you do everything you want to? Oh, yeah, everything I want to. And his daughter was sitting there and shaking her head, no. And so finally I realized I should say, well, tell me what you do every day. And it turns out he sat in his chair and pushed his clicker all day. So, yep, he could do that with no problem. But what a terrible, burden that is, the limited lifestyle.
Yeah. So do either of you use, or do your colleagues use any of the available formats sort of to judge patient burden, whether it's the Medical Research Council, the MMRC, or the COPD assessment test, the CAT, which tries to provide some way of anchoring patient limitations? Do you see those being used, or do you use them yourselves?
Yes, I think they're really important, and I think there's a lot of difference between the MMRC and the CAT. The MMRC, I think, is a really good place to start. If you don't know what your patient can do, I think starting with question 2 on the MMRC, which is, can you walk on the level the same as other people your age, or do you have to stop? And, you can change the words a little bit to fit the patient. I think that's a great place to start because then at least I have some baseline and I can go from there either to worse symptoms or better symptoms. But I don't follow the MMRC because to go from 2 to level 3, which is, more trouble with walking and then can't leave the house, which is, going down, those are big jumps. So I like the cat for following on a regular basis at each visit. I think it really helps you and it helps with more subtle changes. Haley, what
And
do
I
you
would
do?
agree. Yeah, we use the cat as well, and on days when we're adequately resourced and staffed, I share some of that clinician burden with the medical assistant so that when I see the patient, I can monitor the cat. I do primarily see established patients, so that's consistent with what, Barbara was saying.
Yeah, well, one of the limitations, Barbara, has been that one of my colleagues, who you know well, at a major Midwestern medical center, took her a year and a half to be able to get the cat entered into the electronic medical record. So it was a very challenging thing to operationalize.
Well, it is because it can be very expensive to add it. And, in primary care, CAT is not the only tool we have. We have many, many tools. And so it can be very difficult to get all of them in. And sometimes you don't have it in, and you just have to count on your medical assistants or whoever rooms your patients to help you and pull it out when they see COPD. Actually, the front desk now, when they see that the patient's coming in with COPD, pull it out, or we send it by portal before the patient gets there because I don't have time during my 7 to 12-minute visit to have them sit there and figure out the answers to the cat. I want it before I come in, if at all possible.
All right, so that makes a lot of sense. So let me flip to a different related topic, because I think both of you have done a really good job in addressing this issue of assessing symptoms, symptom burden, and some potential strategies. The second major area where there's been a lot of movement in the COPD space is to understand acute events, these exacerbations, which is, was I'm sure you realize, are not infrequent. A lot of patients, in fact, the majority of patients eventually have one of these episodes. And in multiple studies, exacerbations have been linked with a lot of the bad things that we know about COPD: worsening health status, worsening symptoms over time, decreasing exercise. You can name badness in the COPD space and you can link them to exacerbations. So the question now comes: how do you advise your colleagues and their patients and their caregivers to be able to understand how to query for exacerbations and how to try to address that, particularly within a primary care? Barbara?
Yeah, I've stopped calling them exacerbations. I call them lung attacks. I know some people call them chest attacks, whatever, but I think people understand lung attacks because it's comparable to a heart attack. It's an adverse bad event. You don't want this to happen. And so I think that's the first thing I do. But the other thing is that you have to explain, I think, that one of these chest attacks can be light or it can be a full blown chest attack where you're in the hospital. So, can you tell me about bad colds you've had that lasted too long that you eventually called and got antibiotics or you went to the emergency room? So, I think you have to help them understand what they may be seeing because a lot of these more minor ones, oh, it was just a bad cold. I went in and they gave me antibiotics and maybe they gave me steroids. No big deal. Well, it is a big deal. And so I want them to tell me about all of those things, not just the ones where, oh, yeah, I was really sick for 3 weeks or I went to the hospital.
Haley, what do you think?
I agree. And one place where I have been burned before, it's forgetting to ask about urgent care visits. For whatever reason, they don't think about that, and if I simply look in my record, I usually get the ER visits. Those come to me, but I forget to specifically say, "Have you visited an urgent care?" And so I have missed a couple of exacerbations that way. And of course, it's easier if you share an EMR, but that is certainly not the case with urgent cares, and I hope it is with the ER, but not always.
Yeah, I think that's a really good point because whether it's the urgent care at an urgent care center or some of the ones that are in grocery stores or in pharmacies or all kinds of places, and unfortunately, the patients don't think that's a big deal. So you're right, they don't tell us and they don't come back for a follow-up visit. That's the biggest issue, I think, is not having a follow-up visit because I may need to figure out why did you have this event? What can I change? It's not just changing the drugs or it's changing a whole lot of things potentially. And it may be a really good time to jump on that smoking issue.
All right. So let me summarize what I've heard so far from both of you, because I think both of you have provided some really granular recommendations of things that can be used to improve assessment of symptom and symptom burden. So I like the approach that both of you have taken to the query, the way you question, and the use of some of the instruments like the CAT. I think both of you have provided really important insights in terms of these acute events, what the terminology is, and how to assess them. I like this idea of the urgent care, Haley. That's a really good one. And then the way of potentially asking about these acute events in multiple different fashions targeted to where you're practicing, because the language varies in this part of in each part of the country in terms of how we call things. And I think that's been very helpful. Now, let me switch to a different topic because I think that the COPD space has been really rapidly evolving, particularly the last several years when we've actually had very key strategies that have been linked to the idea of phenotypes, in that there are different clinical presentations that therapeutically are treated differently, and how you can extend that by adding endotypes, which is essentially a way of getting a mechanism that can be targeted. So the classics ones are chronic bronchitis and emphysema, sort of the pink puff or blue bloater. We've all seen those at some component. But I think there's been a really rapidly changing space with regards to therapeutically relevant phenotypes. So I want to ask both of you how you present that to patients and your colleagues regarding what some of these phenotypes are that have therapeutic implications. Haley, we'll start with you and then we'll flip over to Barbara.
Absolutely. Well, and I think the biologic space has changed everything. Obviously, now we have 2 biologics indicated in COPD. So it's changed the way I think and the way I educate my patients if they have, say, nasal polyps or what we used to call an atopic phenotype. And that's a patient with maybe allergic disease. And so you go down a little different path of treatment. And sometimes it's difficult to tease that out for the patients themselves because it overlaps so much. What do you think, Barbara?
Well, I think that in primary care, it is still extremely confusing. I mean, we're still at the point often that the chronic bronchitis and the emphysema are not at all clear. And now, chronic bronchitis, okay, they cough and they bring a lot of stuff up all the time. Wet emphysema is what some of my I know pulmonary colleagues call it. So we got the chronic bronchitis, maybe, and maybe you understand there are a couple of drugs that are better at chronic bronchitis than if you don't have it. Although, neither roflumilast or azithromycin are things that are real commonly used in primary care. The emphysema, we're just starting to appreciate that probably because of the lung cancer screening in our smoking patients. All of a sudden, you're getting reports back that's saying, "Ooh, this patient has significant emphysema." And I think we're still like, okay, so what am I supposed to do about emphysema? Is there a special drug? I don't know. That doesn't say that clearly in the gold guidelines, I don't think. And then the eosinophilia. I think we're starting to get the eosinophilia and atopic and allergic. We sort of put that all in just one big thing. Uh, Most of us in primary care don't prescribe biologics. So we may not be thinking, oh, they have nasal polyps and this, and that's better for this biologic than that biologic. It's that, hey, I've done everything I know how to do. I may use the eosinophilia to decide about inhaled corticosteroids, but now the only thing I'm gonna do is, refer and say to the patient, and I think it's very important saying to the patient, "There are some things you have, like the emphysema, that I really need someone else's opinion to help me. Are there other things that are appropriate for you? Are there surgical approaches that are appropriate for you?" And for the eosinophilia, there may be different kinds of biologics, injectable medicines that they're going to think about for you. But that's kinda, I think, where primary care is. Fernando, are there other phenotypes, endotypes?
So let me pose the following fashion, because Haley, you and I both practice in sort of specialty settings. So we usually are getting some of these referrals from our primary care colleagues. So my sense, Barbara, would be that the phenotypes that I see that have therapeutic implications include what Haley mentioned, sort of this overlap with an atopy or asthma component, frequent exacerbators. You both talked about the importance of exacerbations, hypoxemia, because that's a clinically relevant phenotype that's treated. And then there is the topic of sort of hyperinflation with emphysema, which does have therapeutics, but they're invasive therapeutics, lung volume reduction therapeutics. And so, Barbara, how do you envision optimizing for primary care, when and who to refer?
It's a very difficult question. I think it really depends on each of our levels of comfort and how much experience we have with the different therapeutic approaches and how many therapeutic approaches. Do we have pulmonary rehab even available? So I think definitely once I get down to triple therapy, which is a LABA, a LAMA, and an ICS, and they're still not doing well. Usually they have eosinophilia, although I have to say that if I'm up against it and they have lots of exacerbations, I may try the ICS or triple therapy, even when their eosinophil count is down around 100 cells. So once I get there, I really would like another opinion. Or if they're having exacerbations and I'm not sure why, it's not poor inhaler tech, it's not adherence, it's not that they're just still smoking or their partner's smoking. I think I need help. And when I see emphysema on the lung scan, I think that I would like a second opinion. And most of the time, I'm going to go to a pulmonologist. Now, if they have been seeing an allergist because they have asthma that's difficult to control, I might go to the allergist. But usually with COPD, I go to pulmonology.
Okay, so let me pose a slightly different approach, because I want to make sure that we're using our time most effectively. Because you've covered a whole series of important things, Barbara, and some of the non-pharmacological components, smoking cessation, and the concept of inhalers and assessing inhaler use. Can you both sort of briefly mention immunization and your approach to immunization in the current uh, climate?
Oh, I am a big proponent of immunizations, an area I've worked in for a long time. And so I think you say to the patient, these are the immunizations that are appropriate for you. I've looked back, you don't seem to have whatever it is, and those would be certainly the pneumonia, as patients call it, the pneumonia shots, the RSV, the COVID, the shingles, and the pertussis, which people keep forgetting. I think they need all of those, and I'm gonna look and see, and if they don't have it, I'm going to say, "I really think that today we ought to catch you up," or I'm gonna send them to the pharmacist if they have Medicare because it's cheaper for them frequently. But it's just a very prescriptive approach. If they have questions, I'm happy to ask questions. One of the things I think we forget, and you probably see this, Haley, too, if a patient asks me a question about an immunization, it doesn't mean they're denying importance of immunizations. It just means they have a question. Now, if they've never gotten an immunization in their life, that's a little different group. But most people just want to know.
Yeah, yeah. So here, Gold is a whole new section in this latest document on immunizations and providing that information. But let me turn to a slightly different topic. Thank you, Barbara. I appreciate that because I know I've heard you talk about this from a primary care perspective. Where a lot of this is done, Haley. A lot of this is really done initially by the primary care clinician. But now you both have mentioned this issue of eosinophils, and Haley, you started this very early on in this topic by pointing about how sort of how much the biologics are altering the landscape. In asthma, it's revolutionized asthma. In COPD, we're just starting to see that now. And so I'm going to digress briefly by just briefly describing what the Gold Science Committee, I've been on this for years now, has done, which has been to operationalize a process by which we incorporate what both of you have said, how to assess symptoms, how to look at exacerbation risk by prior events, to highlight individual key components that are worth treating in a patient. So both of you have already covered that. And then the longitudinal assessment, in addition to initial therapy, now has been modified by the use of an eosinophil. And that is because of a couple of major reasons. Eosinophils, Barbara, as you said, are associated grossly with the ability of an inhaled corticosteroid to decrease future risk of exacerbation. So they predict responsiveness to inhaled corticosteroids. But as Haley said, they also now are used to identify an endotype, a group of patients in whom that eosinophil is worth targeting. And that has brought in this issue of the eosinophils. And Gold actually has published a couple of documents that have highlighted that above 300 cells, at least once, identifies a patient population that's more likely to respond to an inhaled corticosteroid. And I'm going to come to the biologics in a second, Haley. So hold that thought because I'm going to pose that question specifically to you. If you have an eosinophil count that's less than 100, there is less likelihood of response, Barbara. But in between, as you said, it's up to the clinician to use judgment in terms of when to use one of these agents. So my question initially to you, Haley, and then Barbara to you, is how frequently do you monitor eosinophil counts? Are they now routine in your practice? So you, Haley, first from a specialty perspective, Barbara, you as my primary care clinician galore.
We do. We check them, obviously with the first visit and intermittently, and I think it's an important point to make that you, said, Fernando, once, because, you have to almost trend the eosinophil counts with how often you've given them high dose steroids or they've had an exacerbation, but if you can track back in the last year, if they've had an elevated eosinophil count once, then you can use that to characterize them as a certain endotype that might be open to this type of treatment. What about in primary care, Barbara?
Well, primary care, most of the time, if you look back in the medical record, you will find they've had an eosinophil count because they had a WBC with differential for something. So, most of us, okay, we have a baseline, but it could be a year ago, be 3 years ago, and I may not know how it was in relation to other things. I think the literature until maybe recently has not been clear about, is it one and done? I mean, that was the initial was, okay, it's one and done. I've had one eosinophil count. I got it. I now know it's 256. Uh, but now I think there is this concept that perhaps we do have to recheck. And I especially would recheck if I've got somebody that's on dual bronchodilator therapy, for example, and they have an exacerbation or they have two or three exacerbations, minor ones, and I find out about it. Now the eosinophil count becomes more important because now I'm thinking about, do I use inhaled corticosteroids? I think, unfortunately, in primary care, people still use inhaled corticosteroids as a first therapy for COPD, obviously, frequently with LABA, and that is not an indicated therapy in COPD. It is for asthma, but not for COPD. And so I think we need to get the eosinophilia more as part of our mindset for choosing initial. And then when you move therapy up or change it, I think we need to think about doing it again.
Okay. So that's great. I think that both of you have sort of adopted the party line with regards to the eosinophils. Thank you. But now let's get into some of the idiosyncrasies of eosinophils. And then Haley, I'm going to come back to this issue of the biologics because I want to see how you use them, Barbara, how you would conceptualize this to primary care. Um, the approach that many of us have taken have been to say that, as you said, Haley, an eosinophil count greater than 300 at some point in the last year identifies this endotype. I think we've all sort of agreed on that. And then you mentioned something that is really important, which is as we are looking in the medical record for eosinophils and eosinophil counts, if a person has received parenteral steroids, probably for a month afterwards, those eosinophil counts are going to be really quite low. So, Barbara, I was working on writing a paper on eosinophils, how I do it recently with a group of my colleagues, people that you know. And I spent 4 hours looking through a medical record, Haley, to try to find out every eosinophil count over the last 2 years and a frequent exacerbator, how often they had been hospitalized, how often they had received a parenteral steroid. And Haley, I missed 2 urgent care visits in there where the person had gotten steroids. And so it proved to be really challenging to be able to determine exactly what this eosinophil count was like to be able to make some of these decisions. So, from a practical perspective, how do you two look at the historical record of eosinophils to try to be able to define if low eosinophils reflect concomitant therapies? One, high eosinophil, okay, we got it, that makes sense. But how have you operationalized that? And Barbara, how do you recommend your colleagues operationalize this when they're seeing 30 patients in a day and have 8 comorbid conditions to deal with in a 10-minute period? Haley, you first.
Well, I think that is when we are absolutely lucky to be in specialty practice. And my hat's off to primary care colleagues who also treat hypertension and diabetes because I'm lucky to have a biologics nurse who goes through and does all the trending before I see the patient. She is also very savvy to the phenotype of a patient that might present that may benefit, but then she sees it almost as a fun investigatory thing to go back through the record and actually sometimes even call the patient. I know, lucky. What about you, Barbara? I'm sure it may be different for you.
Well, we'd be thrilled to have a nurse in our practice. Most of us don't have nurses, we have medical assistants, and they're wonderful, but that would probably be beyond the scope of what they would do and certainly beyond the time they would have available. So, as Fernando said, I look back and if there's one that's 250 or above, I have to say I use 250, not 300. Yep, they've got eosinophilia. I don't care if they had steroids or didn't have steroids at that point, it was high. And it's the ones that are having exacerbations and problems. And I look back and it was 80 or it was 120. Well, then I'm going to maybe look, but probably not. I'm going to try to find a time when they haven't had steroids for a month and then check their eosinophil count. What I would love to do is have them come back to visit after an exacerbation or lung attack. So I might have a chance of doing this because, I could see them a week later and say, I'd love to have you come back in a month and we're going to do this blood test. And they don't have to see me, I can just do it.
hold that thought because that's my next topic, Barbara. Coordination of care from between acute care to outpatient. But let me ask one last question, Haley, of you, which is, as you mentioned earlier, there are now two biologics. So we have dupilumab, which was the first approved biologic in the space with really robust findings in their clinical trials. And then more recently, we've had mepolizumab that has been approved in this space. Those will both be in the gold strategy, Barbara. That's one of the questions you had asked me earlier. I can't tell you exactly how it's going to fit because I haven't seen the exact final thing. It's going to be released soon, so we've got to make a final decision. But they'll both be in there because they're both approved and they're both effective. So Haley, since you deal with a lot of these patients in your practice setting, how do you decide between one or the other?
Well, sadly, it's decided for me by the payers for the most part. And again, my biologics person will take their insurance and determine which of those is covered. And that's really the practicality of it.
Barbara, you mentioned that you don't normally see primary care providing biologics, but what's your sense of how you instruct your colleagues regarding how to consider biologics and when to refer?
Well, they are doing it more for patients with asthma now. And so I think as they get more comfortable with the use of biologics in asthma, they will start perhaps thinking about them in COPD, but I don't think that's very common yet. I think that, as you mentioned, Haley, with dupilumab, there are several indications for dupilumab. And so it may be that the patient has some of those comorbidities, whether it's the asthma or the nasal polyps, other things, the atopic kinds of things. So that may be one that you would be able to say to the patient, because remember, I have to convince the patient they want to come and see you and that this is something you may offer them. And so I need to know enough to be able to say, you've got a couple of things here that there's a drug that works now for COPD or is approved now for COPD too. And I'd really like you to talk to my specialist colleague about this. And I think you might find this is great. We've got something for two or three problems. Uh, the mepolizumab hasn't been around as long in COPD, and I don't think we have as much quite yet to talk to them about. But I think that's how primary care probably for now is going to approach it is I need to know enough to tell the patient this is what may happen and this is why I'd like you to go see my specialty colleague, please.
Okay, so those are two very practical approaches. I like this idea of having additional clinical components that can help guide one or the other. But then, Haley, as we all know, I mean, the payers are driving a lot of these decisions for us. So that's just reality. Now, I want the audience again to pause for a second. And I want you to think about something Barbara introduced because this is going to be the last section that we're talking about. And that is when you are thinking about how you want to be able to optimize sort of the patient centered approach to managing a patient. I want you to think about how you have conceptualized the approach to the patient's experiences, the challenges of what they want, and how we transition care. Think about that. Barbara and Haley, you know what's coming as I'm going to ask you next. All right. So as our healthcare system has become fragmented, not a bad thing. I mean, it's just the complexity of the healthcare system. Haley, you've already pointed out the challenge of getting information regarding urgent care. Yep, there's one right there. Barbara, you just highlighted the question regarding how you envision optimizing transitions from care from either an ED or inpatient setting, where a lot of the care is provided by a different group of hospitalists, specialists in hospital care, versus communication with either you, Haley, in your outpatient specialty practice, or Barbara, you in the primary care. Barbara, you first, and then Haley. We got to give people some practical advice here.
Well, I think the practical advice is let's communicate. We'll try through the medical record, but the medical record doesn't always have it all. So I still like getting, if I refer somebody, I want to send a note with them telling them why I'm referring and any little idiosyncrasies that might be there. Why? Because I know the specialist looks and says, "Well, why the world didn't you send this patient 3 years ago?" Well, because the patient wouldn't come 3 years ago. So I need to explain to you what my questions are, what the patient wants, from what I know anyway, and why I'm sending them to you now. And when I come back, I would like some explicit answers to the questions I ask. But if I don't ask you a question, you don't have any idea what to answer.
Yeah. And the feedback agreed. The feedback I get from my primary care colleagues, and there are many, um, in especially primary care nurse practitioners, is that they finally convince the patient, as Barbara reminds us is necessary, but then they call our office and they're given a 4-month appointment. So what happens a lot, and I'm so open to, is a HIPAA compliant text from a colleague regarding the patient telling me just what Barbara said. What's happening. Finally, they've agreed to do it. If we wait 4 months, they probably won't come. So then I'm happy to overbook. So I think we have to go back to the days where we picked up the phone and called one another, maybe not in the middle of a clinic where you can answer a phone call, but a HIPAA compliant text will go a long way. And as Barbara mentioned, sending a note with the patient. That is very effective. We've all been unable to find medical records before, and that really takes out the middleman.
One of the things that just quickly too is the patient portal. I ask questions in the patient portal of my primary care, of my specialty, of whatever. And I have to admit, as the clinician, I will go back and look at the patient portal to see what they ask that I didn't even know they ask about. It can be very enlightening.
I was just before this call looking at my electronic medical record, and I had 38 messages from various people about this. So you know what it's like. I mean, it just gets overwhelming. I like this idea of having a note and the pages in front of you. Look, right there, that's what happened. Let me ask you one last question, because we're getting short on time here, and this is also regarding the complexities of our healthcare system. So, Barbara, your patient calls you and says, "Oh, that inhaler is no longer covered. The pharmacy is going to switch me to this one." And then Haley, the payer says, "You're no longer being covered for biologic number one, but we'll cover biologic number two." How do you guys deal with that with patients and their family members? Barbara first, and then Haley.
First of all, I would be thrilled if the patient called back and told me they got a different inhaler. Frequently, they don't. They just take it and go. And it may be they move from an MDI to a dry powder and they have no idea how to use the dry powder. So, the first thing we always say is if you don't get this exact medication at the pharmacy, because he may change it or she may change it for cost issues, please call back and tell us, and then we have a chance of knowing. Most of the time, it's an acceptable change, but we got to make sure they know how to use it. So I need to know what they got, and that is not always easily found in the medical record. Oh, and by the way, when the patient comes in, you ask them to bring all their medications and all their inhalers because they don't think inhalers are medications. So you got to say the magic inhaler word and nebulizer.
All right, Haley, your last chance in 30 seconds.
Oh my god. So, we have had some success with calling the payer directly and using either the comorbidities or the fact that they've not had an ER visit in the last 30 days. And before we leave, as we're prescribing these subcutaneous injections, it's a great time to tell the patient that they must take their vaccinations as well because it's the same type of therapy. So I wanted to squeeze that in there.
Look at you being efficient. I'm very impressed. It's very good. All right. Well, listen, thanks to both of you for really a lovely discussion. I think that, yeah, COPD. Oh my God, COPD action plan. All right. So yes, I understand. I'm not looking at all these slides, is because we would spend 45 extra minutes looking at all the slides. And so, realizing that, Barbara, the whole story behind action plans. It's a controversial topic in the COPD space, regarding action plans. And so I'll ask this question, but I need both of you to just be careful in terms of how we answer this, because this is a loaded topic in the COPD world. Okay, Haley, this is in part because there's a classic study of a COPD action plan that was done out of the VA that was terminated because of excess mortality. And so even in gold, we just had this long discussion regarding action plans and had to rewrite the entire document in gold and the action plan to make it very nebulous in terms of recommendations. So Karen, that's the problem with action plans. Decision support, I think, is a perfectly reasonable thing. Haley, what were you going to say?
This is interesting to me too because yeah. Do you if you had the action plan without the antibiotic at home to initiate on your own, do you think that's less controversial? Is it the antibiotic that
It's not clear. I mean, I think that I was the DSMB of that part, but this is the classic VA study that David Howe read. And what happened in that study was that patients felt empowered and they died of cardiovascular events. And so they were ignoring symptoms at home. And so that became the problematic issue that took place. There've been other subsequent action plans studies that have been more favorable. But really, just having gone through this all in the Gold Science Committee at the ERS, it was another source of a lot of discussion. And John Bourbeau, Barbaras, who's trying to rewrite that section. I haven't seen the latest version, although I did get an email from him this morning about that. All right, so let me ask both of you. I'm going to follow up essentially, Karen, and on Haley's last comment as a way of introducing that topic. Okay, you two ready? All right. So Haley, that last comment you made is an interesting comment, and so if both of you could give me a sense of what approaches you would use to sort of empower the patient as they're interacting with you to optimize their outcomes, adherence, medications, and so on. What tools do you think would be the most relevant and easy to utilize? Haley, you first, and then Barbara, I'll let you finish off the program with your comments.
Sure. So we do use the COPD action plan very carefully. We ensure that the patient does still call the office, and our triage nurses are trained to ask if they're having any cardiovascular symptoms as well. But we do help them sort of sort through and tease out their symptoms with the COPD action plan. Barbara, what about you?
I also really like the COPD plan because I see it as a teach back method. I don't usually use it to tell them what to do with their medications, except it is okay to use a quick reliever rescue medicine. But, I have a limit on how many times. But I think it's a really good way to tell them it's okay to call. Do not ignore your symptoms. If this is happening, please call. And that little 911 section, if you can't talk in full sentences, if you can't lay down, if your fingernails are turning blue, call 911. Don't think about it because it's Saturday until Monday. So I see it as a way for them to kind of say, where am I? Am I doing okay? Or am I having problems? Or am I really having problems? So that's the part of the COPD action plan I use, is to help them understand where they are in this. It's okay, a mild exacerbation, or this is a big deal. Act now. And that would be the same whether it would be cardiac symptoms or respiratory symptoms. They need to get help now.
All right. I like the way you both have utilized the concept of this action plan for impairment, particularly for communication strategies. I think that makes a lot of sense and it's very practical. All right. So let me summarize this. Thank you, both of you, for really excellent points that you've made, very granular recommendations. Let me just sort of summarize what I've heard, which is both of you in two different settings, primary care and a specialty setting, have developed formats to enhance the assessment of symptoms, symptom burden, and exacerbations, working with the patient and their family. So that's great. I think both of you have provided insights regarding how you clinically and biologically separate patients into treatment groups given the different therapies that we have available. So you've adopted the phenotype and endotype approach. That's great, both in specialty and the primary care setting. And I think both of you have provided additional insights regarding how to maximize the communication strategies with the patient so that we can assess when patients are worsening either chronically or acutely. And I think all of that has been remarkably practical. And I appreciate both of you for providing all those insights.
Thank you.
You.
All right. And for those of you that are on, I hope you've stuck around to listen to this entire component. Uh, Please answer the questions that follow and complete the evaluation. And again, thanks again for listening to us.